thought that was absolutely vital for our region in particular. After a huge work that you'll see the time that it has taken us and all the people that have collaborated for this to be ideal.
I have some recommendations to you, especially because you have an icon at the bottom of your screens where you can identify the icon of the word. If you click on the icon, you have the possibility to select the language of your convenience. This webinar will be in English and Spanish, and also if we have more people at the level of the chat, you can find the different link for the YouTube channel, and when this presentation finish, you can see the all meeting in the same links. Well, volviendo al español, les doy a todos.
Going back to Spanish, I want to welcome you all again. We'll have an opening session right now. We'll put a video that was sent by the head of the Department of Family Course of Life, where CLAP is. Dr. Andres de Francisco sent us this video that you will be able to see as an opening video in the course. I'm so glad to welcome you to this course on the respectful maternal care, organized by CLAP and together with very important partners. I'm Andres de Francisco. I'm the director of the Department of Family and Course of Life in PAHO. And at PAHO, we understand the role that the healthcare teams play to provide a quality of care as consistently with the sustainable goals, so as to provide good care during pregnancy and childbirth, and so the improvement of maternal perinatal care based on the evidence available is a continuous interest of our organization. And within this quality framework, we promote the perinatal care focused on the woman and her baby. So the emotional support, among others, are essential elements of the quality of care. Despite the progress in the last decades, abuse and the lack of respect are still an everyday experience in many centers. So in its commitment to change this situation in 2014, the World Health Organization published the declaration on the lack of respect and abuse during childbirth care at the healthcare center, supported by over 80 organizations, and recognizing the woman's right to receive a decent and respectful management during pregnancy, and to be free from any discrimination and violence during childbirth. However, PAHO and WHO consider that together with the absence of not only do you have to be free of violence, but also that all the experience related surrounding childbirth need to be positive for the woman and the baby. That is why in 2019, WHO issued the guidelines for a positive childbirth delivery, and recently a toolkit was developed for the 23 recommendations at a national level. Under the quality of care framework, pregnant women and newborns with this course that was specifically designed for healthcare providers, but also adequate for managers and government representatives and of the civil society and other people interested in the promotion of the respectful and quality maternal and childbirth care. We want to raise awareness among the participants on the concepts related to this and the framework, right, supporting it so as to provide some of the tools available to plan, implement, and monitor the initiatives for the improvement of the quality of maternal and neonatal care at the healthcare facilities. So I invite you to go through the modules of this course, this training, and to implement what you've learned in your countries and to decisively continue to work for the improvement of quality of care of mothers and newborns so that each mother and child may be the protagonist and may enjoy a good experience at birth. We thank the video that was sent by Dr. Andres de Francisco. And now let's go on with the meeting. I am very pleased to present Dr. Suzanne Saruya, not to introduce her because you all know her, but she's the director of the Latin American Center for Perinatology. And in addition to that, she's the director of the Women's and Reproductive Health of PAHO. Suzanne, you have the floor. Thank you, Bremen. I want to thank each and all of you for being with us today. Today, very specially, today, we are on the 16th day of activism against gender violence. That's why I'm wearing orange, because we have to work very strongly in that direction. That it was this coincidence that led us to launch this course on the respectful maternal treatment and a perinatal which includes the newborns, makes us very happy, because if we think of the whole course, the evolution of everything that we managed to improve maternal health, there's something that always leads us to think very deeply. So we make progress in evidence and in studies. However, respectful treatment, free from any violence, and giving autonomy to each and all women based on their culture and in their own style, that's something that was missing. So sorry, there are dogs in the building that are barking. It wasn't until now that we started producing documents that are especially documents of policies that need to be adopted by all the member states against gender violence. Today, we're going to launch the course. I won't speak of the modules of the course, nor will I talk of all the content. That's something that the lecturers will give, whom I thank now. But I wanted to talk to each and all of you that are with us, because we have an opportunity to have these discussions in every place and with each woman. We have to recover the most basic things at birth. Birth is a key moment in all the families. I always say that all of us are capable of remembering what our mothers said, and those of us who already have the privilege of having gone through childbirth, whether it was ourselves or in the case of man or in the case of two women, whatever, we've had the opportunity to see the key role that plays in a family and a society. So it is not acceptable. You can't allow to mistreatment to a woman, a colleague, a partner being disrespected. So we just discussed prematurity. And I said that when we go through the evidence, and today when we issue recommendations, sometimes it sounds even absurd for us to have to present evidence to make such obvious recommendations. And let me remind you of three. The first has to do with the court. We haven't been able to uh, um, convince the team that is providing care to be as patient as to wait until there are no more beats in the court. You need to give patience for this link to be closed. That's something that we know, and we know how important it is based on scientific evidence. And the next thing is that the mother, the family, we need to enable them to receive the children and to allow for skin-to-skin contact. And we also had to look for evidence to convince the teams. And finally, we we need this to be earlier and earlier. So what I'm telling you today is that mankind that is recovering, and hopefully we will see that it recovers. We improved many things, but we have improved things in obstetrics, in perinatology, and in many fields. So we've done a lot to save women, but in addition to that, of course, we have to respect them, and that is why we are practicing activism against gender violence and violence in the delivery rooms and the places where the women bear their children. There is gender violence, so we have to work at that. And I'm very happy to see how many partners we have. I very especially want to thank Gabrielle, who will speak from here and tell you that you are going to have a wonderful tool to use and to learn. And I would add more. I want to invite you all to write to us and to see the course and to say, Suzanne, Bremen, this and that, I didn't like this, or we wanted this or that. We might improve that. So we send us your feedback. We love that, and we love to receive you today. And before we finish, I want to thank our two international advisors, Bremen, in charge of maternal health, and Pablo Duran for neonatal health, with all the work, together with Ariadna, who has worked with them so as to develop the course in the best way possible. I'm sure that the entire session will arouse your interest, and thank you all. And Bremen, you have the floor. Thank you, Suzanne, for your words, for your welcome words. And now we are going to start with the scientific activity that we have included
pain, gross violations of privacy, refusal of admission to health facilities where women have to tour centers to find one taking care of them and sometimes reach them in very poor conditions, late and even die, neglecting women during childbirth to suffer threatening avoidable complications, and detention of women and their newborns in facilities after childbirth due to an inability to pay because of different reasons. This does occur in our region. Among the many issues approached in this declaration, it is stated that generating data related to respectful and disrespectful care practices, systems and of accountability and meaningful professional support are required. We're far from that. And next, we'll see the difficulties we'll have to have solid data allowing us to design policies and guarantee these outcomes. Health systems must be accountable for the treatment of women during childbirth, ensuring clear policies on rights and ethical standards are developed and implemented. Similarly, healthcare providers at all levels require support and training to ensure that childbearing women are treated with compassion and dignity. And we'll see a study that was published last year by a Mexican colleague that speaks of the positive impact of training health personnel to have better outcomes. Those health services that already provide respectful maternity care, the idea is promoting participation of women and communities. Indeed, some already have done so, implementing processes to track and continuously improve respectful care. This is essential. The community and families must be involved in these processes. Observe. This has been obtained from a table of a document published by WHO in 2018, that is WHO recommendations for a positive experience during childbirth, and since 2019 are also available in Spanish for those who may wish to read it in Spanish. Observe that they include respectful maternity care. Through respectful maternity care, which refers to care organized and provided to a woman in a manner that maintains her dignity, privacy, and confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during labor and childhood. Effective communication between maternity care providers and women in labor is also recommended. We must be aware of this because we speak with Spanish-speaking people with medical terms that they don't understand. But in our region, there's great diversity. Now with migration, we must try to get the message, reach them in the simplest manner possible, in a language that they can understand. A companion of choice is also recommended for all women throughout labor and childbirth. We still have laws in some countries to guarantee this, but in practice, we see that women who generally access this practice are those who are wealthier, with better social and economic situation, and those with greater vulnerability do not achieve that right. Observe this. Here we have a systematic mixed review. It has qualitative and quantitative studies. This was conducted by Warren 2015, including 65 studies in 34 countries, where Warren suggests a typology of mistreatment during childbirth to share common criteria. It's a busy slide, but he mentions 7 dimensions: physical abuse, sexual abuse, verbal abuse, stigma and discrimination, and failure to meet professional standards of care, poor rapport between women and providers, and last, health system conditions and constraints, because sometimes they don't have the necessary resources. This systematic review demonstrates that mistreatment may occur in the interaction between the woman and the provider, but also due to failures in the facilities, in the networks, and at different levels. Warren suggests that this typology be adopted to describe the phenomenon and to develop measurement tools and inform in future research and designing programs and interventions. And I think this is totally feasible. This is another study, the one I quoted by Dr. Alejandra Montoya. She's from Mexico, and she establishes as listed that often women are disrespected and are abused during birth. Evidence-based practices are seldom used or applied, while outdated and dangerous procedures are still applied. Disrespectful and abusive practices have been reported in Mexico, but are not necessarily well documented, and none of the prior studies had conducted direct observations of what occurred during childbirth. These researchers observed close to 401 births in the 2010-2016 period and analyzed women, provider, and hospital characteristics and their association with the performance of 14 evidence-based and 15 respectful birth practices via descriptive statistics and multiple logistic regression models. Incredible. In these over 400 births, they only found that these 29 practices had been conducted only in 4, that is, in 10%. Essential interventions, such as uterine massage, were only conducted in 46% of women, when we all know we should try to reach 100%. Uterotonics that are capital to prevent postpartum bleeding were only applied in 58% of deliveries, and professionals, and this is interesting, who were trained in respectful birth care were more likely to address women by their name in a more empathic manner, to allow consumption of fluids during labor, encourage skin-to-skin contact, and examine the placenta after birth. And in turn, they were less likely to perform episiotomies. This study revealed low rates of evidence-based practices and respectful maternal care, but demonstrated, and this is an interesting thing, that the staff that had been trained had more positive behaviors as compared to the rest of the colleagues. In this study by Afulani, conducted in Kenya in 2016, she studied the lack of respect and abuse during childbirth, a mixed method study in Kenya. 49 providers, 32 clinicians, and the rest were not and worked in a rural center in Kenya. The suppliers were asked about questions about structural abuse and disrespect, followed by questions about certain behaviors that occurred or didn't occur. Most providers initially reported that often women were all treated in a dignified and respectful way. However, 53%, although they said they were all well treated, reported having observed other colleagues or providers verbally abuse of women, but later 45% of those interviewed reported that sometimes they themselves had this sort of behavior. Similarly, with other variables such as physical abuse, and the people who spoke of disrespect and abuse stated that from their standpoint, this was because some women were hard to treat and that stress and exhaustion led them to these behaviors. A culture of the facilities, a lack of responsibility or accountability, lack of medication and other supplies, a large amount of variables that they said impacted on all this. Look at this graph. This was using what I used after research following 2014, where we had the publication of the WHO declaration, to see publications regarding different issues regarding respectful mother and child care. In 2015, observe, 1 year following the declaration, we only had 6. In 2016, it rose to 9. It has continued to increase indeed in 2020, and in spite of the pandemic, we saw a large number of studies. This year it's 71, but we have figures up to October, so maybe the figure will be greater. But what happens when you look into them in detail? Observe, in 2015, we couldn't really tell which were the countries in Latin America. We knew there was a Latin American study where people from Brazil and Mexico had participated, but the people leading the study were from a US university. In 2016, something similar. In 2017, 18, the region didn't publish anything, at least indexed in PubMed. In 2019, we had 2 studies, one from Brazil, another from Guatemala, the latter together with a US university. In 2020, 1 single paper from Mexico, and 21, 2 from Brazil and 1 from Mexico, showing that at academic level, it seems we're not extremely interested in knowing what's occurring in this area. And if that is so, this won't have visibility, and if so, we won't solve it. So, and these are my conclusions in relation to this presentation. We don't yet have standardized definitions about respectful mother and child care, so the data we obtain cannot always be comparable. Despite the little evidence, abuse and mistreatment figures are extremely high in maternal care services, according to what we said, for example, in the Kenya and in the Mexican studies. The health providers generally speak of inappropriate care in their colleagues, but they don't always identify themselves as mistreaters. We saw this in the Kenya study, and apparently the positive or the upside is that the training of health professionals on this issue makes for an improvement. And if this is indeed so, I believe that having this course we're launching today may be an excellent first step. Well, colleagues, thank you for your attention. Now we're going to have a better part that will be chaired by my colleague and person responsible for this course, Dr. Pablo Duran. The floor is yours.
Muchas gracias, Bremen.
Thank you, Bremen. Thank you. Good morning, good afternoon, everybody. It's also a pleasure to, it was a joy having been able to work for this course and reaching this moment. So let me go on with the same ideas that Dr. De Francisco, Dr. Saruya, and Murcio already mentioned. The previous speakers have mentioned already that despite the fact that it's so obvious, and everybody, it is very clear that we need specific interventions. We haven't been able to accomplish them yet, and women and newborns don't have access to respectful and quality care. We also know that there are positive experiences, however, that can shed light and illuminate and set an example for other services so that this will become effective. So that is why we're going to start a panel with the 2 outstanding speakers with a lot of experience from looking at it from the neonatal point of view and the maternal health point of view. So can we share the screen to introduce our colleagues, and there we see that the colleagues that will share the experience are Dr. Constanza Soto and Dr. Veronica Reyes. Dr. Soto is a pediatrician and neonatologist, and she works at the Ramon Sardá Maternal Hospital, Maternity Hospital in Buenos Aires, Argentina, and she's the secretary of the Fetal Neonatal Committee of the Argentine Society of Pediatrics. Dr. Veronica Reyes is a doctor. She is specialized in obstetrics. She has a master's in public health and a PhD in international health, and she's a senior technical advisor of Momentum for maternal health and reproductive health, and she's a member of the executive committee of the regional working group for the reduction of maternal mortality in Latin America and the Caribbean. So today, the intention and the invitation is to talk with both colleagues about your experience on the implementation, the approach, and the surveillance of compliance with the respectful maternal and neonatal care. So it's a pleasure to receive you, Veronica and Constanza, and to have to learn of your experience. Let me start with a question for Constanza. Constanza, could you tell us what does the safer and family-centered approach that you implement in Argentina and specifically in your unit? What could you tell us the history and your experience so far? Thank you, Pablo. Yes, thank you for the invitation to participate in such an important moment. This is a very useful tool to implement the model. The safe and family-centered model is a paradigm of perinatal care. It's an ethic and philosophic conception of how we approach practices, and the key concept is that the true protagonists of childbirth are the pregnant women, the newborn, and their families. Hence, the birth until the early 20th century occurred at home. Those were intimate experiences, and only the very close people were there. But as technical and scientific progress took over, we managed to reduce mortality rates, but we institutionalized the births, the childbirth. So there, it's the preponderance falls on the healthcare teams instead of the mother and the newborn. So today, with all our knowledge so far, we should be able to put all the knowledge together. And we need to be aware of how joyful this moment should be, and put that together with all the science and technique and all the technical knowledge that we have to ensure a safe birth. At Sardá, Alfredo Maria came here from the Gutierrez Children's Hospital, and started implementing certain practices that seem to be just common sense, but today evidence has been generated for that. Those practices were not planned, but they gradually took over, and they are strongly based in the 90s, where the hospital, where WHO, UNICEF started appointing the friendly hospital. So Dr. Laria developed that knowledge, and it was learned by the people who work in that maternity. Dr. Larguia developed a guideline to transform the maternity so that they could be family-centered. The representation of PAHO in Argentina assessed it as a successful model that happened in 2008. And from 2010 to 2012, the big challenge was to replicate the model and to take it to perinatology departments throughout Argentina, but the greatest challenge has not been overcome yet, and it is that shift of the individual paradigms, where everybody involved in perinatal experiences, everybody working in the care of the pregnant women and in the surroundings of childbirth, we haven't all changed our philosophical view of this, because this has an impact on people's lives, and we know that respecting that moment and to apply evidence-based practices are key for a child that has just been born, and ensuring that breastfeeding gets started successfully will have an impact in the future. And only a society that is built with made of healthy people can prosper. So I think that this highlights the importance of the perinatal teams. Thank you, Constanza. That was absolutely clear. And it is surprising to see a 45-year history of people working to promote this model, but also we are not surprised that despite all that time and despite the work, there's still challenges. And as you pointed out, the main difference, the main challenge continues to be the paradigm shift and the different way of looking at it from the point of view of human resources. So my next question is, from that point of view, what has been the experience surrounding capacity building, strengthening capacities, and training others, people, so that this same view may be shared and enrich our daily practice? What has been your experience? Because I think that the course will be important, but we'd like to hear how you approached it when training your human resources. In 2007, when the guideline was published to transform the maternities into family-centered maternities, at the time, we started with the training of human resources, and we started replicating the model in other maternities. However, and a lot of progress has been made in the focusing on rights. However, there's still a lot of do, and I would say that there's a huge gap between the different facilities, the different regions, or even within the facilities. I think that we've made a lot of progress. At Sardam Maternity, the progress was focused especially in the new generations of young doctors. Just to mention some of the professionals, because the perinatal team is formed by professionals and non-professionals that assist us. And that this has been done. A lot has been done, but there's still a lot to do. So I think that this is a key course. And there are even inconsistencies between the different sectors, the different specialties. We haven't been able, and different days of the week even, we haven't managed to get an even environment. So the greatest challenge will be to standardize this, everybody and all the facilities, all the centers, so that all pregnant women may have access and to be respected and receive their children happily. So because that will have an impact in the future. And I think that the progress is with the new generations, the younger generations. And personally, I think that the trainees need to already have notions about this, because that may define the call for the specialty. When you choose to this field, it has implications. It's common sense, but it also is evidence-based. So there we start to receive people that are being trained.
And then, as we have new generations, we must train them with this view. this work paradigm. Thank you, Constanza. What you say is extremely important, not only in terms of counting with tools to train human resources in general terms, as you stated, the whole health team, but also in pre-graduate training and residents, interns, and so on, because we sometimes focus on clinical skills or surgical skills according to specialties and biological and clinical aspects, and not so much in including both in the pre-graduate and postgraduate training all these points of views, because it might be late after. So thank you for specifying this. That is so important, and let's hope that for those participating in this seminar become motivated to access this course, but also include it in the pre-graduate and postgraduate training. Thank you, Constanza. And this leads us to something else, because modifying practices and culture requires, as you well stated, training human resources and a whole monitoring and permanent surveillance process, allowing us, as in clinical monitoring, to be warned about physiological changes to intervene fast. And if we don't include these aspects in the monitoring, they will continue to occur and will have actions we don't want, that is disrespectful and inappropriate treatment. This is why I'm going to now ask Veronica, because of her experience in monitoring and assessment of the implementation of interventions to promote respectful maternal and neonatal care. What is her experience regarding the strategy implemented in Mozambique for monitoring and assessment, that is, lessons learned from her experience? The floor is yours, Veronica. Thank you, Pablo. To start, I would like to compliment PAHO for launching this course, which I believe will be extremely important in the region. And thank you for allowing me to share with you our experience in the promotion of respectful maternal and neonatal care and supporting countries to monitor and assess progress made in this field. I would like to add that I started with this work when I was in the Ministry of Health in Brazil. I had the chance to coordinate the national humanization of delivery and childbirth program, and I learned a lot there. And then I worked at regional level and then continued working at global level, and I'm very pleased to share this interest and investment to promote respectful maternal and neonatal care. This has increased in the past years at world level and also in different regions and countries. To answer more specifically your question, I would like to share a few slides by way of illustrating what I will now state. I observed this question we have in the chat about how to monitor and assess the impact of interventions on respectful maternal neonatal care. And I'd like to share the experience of a country where I had the chance to live, and that was Mozambique in Africa, and the efforts made there to promote and monitor respectful maternal and neonatal care. But I would like to make some initial general considerations, saying it's fundamental to monitor and assess, but unfortunately, we don't think there's one single method allowing us to have a complete overview of maternal neonatal respectful care or mistreatment or abuse. So we need to seek information and different data sources that could include the National Information System, medical records, surveys, questionnaires to clients and workers, people who are accompanying the woman during delivery, focal groups, direct observations, and unfortunately, the national information systems in general do not include indicators and mechanisms to measure different issues regarding respectful maternal neonatal care. And I'm very happy to say that there are some efforts being made at country level and at regional and global level to develop tools helping us out in this process. Here, I'm showing only a few. One is the Charter of Universal Rights of Women and Newborns, published in 2019, that includes 10 statements or declarations about women's rights and newborns' rights during delivery and childbirth in general terms. You can access this document in this link. And then we have the International Initiative for Childbirth that includes standards regarding respectful maternal and neonatal care. This is an initiative championed by FIGO and also another international association, IMBCO, and have support from Flaxo and ICM. Raman has already mentioned the efforts made in WHO, and we have the framework of quality of care and provision of care published in 2015, including indicators and standards regarding the experience in care and technical aspects of promotion of care. Regarding the Mozambique experience, I would like to briefly tell you that this is a country in the south of Africa that has a population of close to 24 million inhabitants and a maternal mortality that when I lived there was close to 108 deaths per 100,000 live births, extremely high. And neonatal mortality was close to 30 per 1,000 live births. And institutional delivery coverage, well, was nearly 50%. I worked at the Ministry of Health in Brazil, and I moved to Mozambique to support efforts made there to improve the promotion of high-impact interventions to reduce maternal mortality. And at that time, I was thinking as an obstetrician that I had trained people to manage postpartum bleeding, hypertension during pregnancy and delivery that were the main causes of death and infections. However, when I reached the country, I observed that many women didn't want to come to the health facilities because they were fearful of the manner how they would be treated there with a lack of respect. And working in the health ministry, I had the chance to introduce this issue about respectful maternal and neonatal care that has been very well received by the Ministry of Health there. And the country began to make efforts, and more particularly in this area of promotion of respectful practices, but also measuring efforts. What the country did was define standards regarding respectful maternal neonatal care. And I included these standards in a list of quality standards and improvement of quality. And at the time, it only included more technical standards. Following this process, there has been an agreement about standards that were also related with the manner how women and newborns were treated at the health facilities. Based on the definition of these standards that included people of several levels of care and in the community who participated in the process to define standards, Well, after that, the ministry tried to spread these standards and train individuals to implement them and also define mechanisms to evaluate this process. I will stop here to see if you have further questions so that I can continue with the experience in Mozambique. Thank you, Veronica. Indeed, what you have said is very important indeed. And according to what you mentioned, I was thinking I could ask if you could share or specify about the monitoring and assessment process implemented in Mozambique. What do you think is more relevant when establishing the monitoring process? What indicators or issues have you considered would be more useful to evaluate the progress or lack of progress in the strategy? Yes, thank you, Pablo. Well, in this sense, I would like to show this graph that is a sort of the outcome of the measurements, because as we said, Mozambique defined standards and likewise developed tools to observe these standards in the health facilities. So the units trained regarding these standards and the health ministry created commissions in the different provinces in the country to support the efforts made in the health units, but also to monitor, identify the situation and progress. So in the graph, you may see that, for example, in an initial measurement conducted in 2009, most standards were below 50%. Some were related with facilities, infrastructure, working conditions, capacity of professionals to implement evidence-based practices related to respectful maternal and neonatal care, quality of pre- and postnatal care, quality and humanization of care. So there were standards at different levels, and initial measurements showed that the units were ultimately below 40%. After some investment was made, there have been other evaluations. In 2013, a graph shows that there was a general increase in the different units. Most were above 50%, and some even reached 80%. This was an effort made during 3 years. Observing these standards involved direct observation, revision of medical records, interviews with the health personnel and the women at the health units. For example, here we have documentation that included pictures of the unit prior to the efforts and after the efforts. For example, in this area with the infrastructure. This other graph shows direct observation and assessment of records. And I would like to say that the Health Ministry conducted a revision of their registry forms in order to include at national level indicators related to respectful maternal and newborn care. As you can see, this graph shows specifically 2 indicators related to newborns and 2 related to maternal care. We will observe that in 2009, all these indicators were at 0, meaning that they included if the women had the possibility of having a companion during labor and delivery, if deliveries could be in a more vertical or semi-vertical position. At the time, no women had that right to have their delivery in the position of choice or to have a companion. And then newborns. There was an indicator related with skin-to-skin contact, immediate skin-to-skin contact, and breastfeeding within the first hour after delivery, and national standards in 2009 showed that none of this was being implemented at the units.
Esfuerzos en algunos años se pudieron documentar para los indicadores relacionados con el recién nacido, el aumento fue realmente impresionante. Las líneas verde y azul ahí están mucho más
por. Green and the blue curves are well over the indicators related to the women. There was a very significant increase with the position at delivery after over 60% in 2015, and the possibility of having a companion during labor and delivery in 2015 was around 20%. I left Mozambique in 2016, and that is why I know that the chart, I finished that chart because I was living there, but that indicator has continued to grow in that country. So it's very important that the Ministry of Health has succeeded in institutionalizing the monitoring and measurement of indicators related to respectful maternity and neonatal. And finally, the units included boxes to receive the feedback of the women and the families that came to bear their children. And so it's necessary to keep record of the feedback, of the comments of people, and to use them so that based on that we can continue to improve the quality of care. Here we have some things that were said by people attending those facilities. So these are some of the mechanisms that have been established and that made it possible for the Mozambique government to monitor. And on the other hand, I wanted to say that there was an assessment in Africa with the support of several international agencies. Mozambique stands out as a country that is doing very concrete things with the ability to monitor the progress in the field of respectful maternity and neonatal care. Thank you, Veronica. And as you said, the results are quite impressive. And that leads me to analyze, based on the two presentations by Dr. Constanza and yourself, three key elements. One is for the achievement of the implementation of respectful maternal and neonatal care. One is the decision that, as Constanza said, Doctors Alfredo and Miguel Larguilla at the Sardá maternity, and that was followed by the Ministry of Health, and then in Brazil and in Mozambique. If the authorities had not the healthcare administrators and the national authorities, unless we have everybody's support, it's impossible for the change to take place. But as Constanza said, if you don't have the training, if you don't have the advocacy with human resources, you won't be able to reach the achievements that you expect. And in the Q&A, they said they talked about involving the obstetricians and the midwives and everybody in this. Yes, all those people need to be included, but from the janitor to the person to the clerks and everybody at the hospital, at the maternity, need to be involved. And Veronica, you mentioned the third thing, and that is to have indicators to allow for surveillance, for monitoring, so as and as you showed in those colored curves, how changes take place, or you may also see that there are no changes. So once again, I wanted to thank both of you because of your very, very clear presentations, and I want to thank all the participants, and I hope that this was of interest, and it's inspiring for you to make progress in this field. Now, let us give the floor to Bremen, who will continue with this. Thank you, Pablo. I also want to thank the colleagues that helped us. We are getting closer now to the presentation, to the specific presentation of the course itself. And in order to that aim, Juan, could you put the slide? First of all, we're going to have Gabriel Listowski, our colleague from PAHO. He's the regional coordinator of the Public Health Virtual Campus of PAHO. Gabriel is in the unit of human resources in the health services system unit. And then I'm going to recognize Ariadna Capasso, who is receiving her public PhD and although she has a very extensive background, and they have collaborated with developing this course. So, Gabriel, we are eager to hear you. Good morning, everyone. It's a pleasure to be with you for this opening. First of all, let me congratulate the entire team at CLAP, headed by Suzanne Saruya and Bremen and Pablo Duran and the entire team for the excellent work that we've been able to develop together this year. It's a pleasure to continue to share projects and activities in this virtual campus of the Panamerican Health Organization. From the virtual campus, we consider that it is essential to bring knowledge closer to practice. In that regard, the work that you are developing is absolutely key, because it's key for each of the pieces of research and all the papers, the work that you have actively developed. It's important for them to be expressed and translated into everyday practice at the healthcare services. Let me share my screen. There you are. I assume that you can see it there. Now, let me just devote a couple of minutes to describe this educational platform of the Panamerican Health Organization. We're over 15 years old, and we have over 1.5 million users throughout the Americas and also globally with our English, French, and Portuguese versions. And I'm sure that many of the people that are participating in today's meeting, over 3 million people that have registered for courses. So there are many of you that have already taken some of our courses, and starting tomorrow we're going to have this course available and you'll be able to register in the new course. So for those of you who are not familiar, there you have the virtual campus, and there to your right on top, you must create an account. If you don't have an account there, we invite you to register. The campus works in Spanish, English, Portuguese, and French. There are some slides there that in English, others are in Spanish, thinking that we have many people from different places here. And please be aware that tomorrow you will have the version in Spanish and in English. Each of you can create an account if you haven't done it yet. Just as any other account for the bank or for all our activities. This is part of our everyday work, and it is part of the life of healthcare workers too. Over 37% of the users of the virtual campus are staff of primary healthcare centers. About 47% of them are doctors of the first level of care, many nurses and midwives. So I think that this course is really wonderful for those population, and something very important for us and for CLAP. Year after year, the campus has grown in the number of users with health sciences students. We want the contents to be we want to create ownership among all those students so that when they go to reach the places of work, they can incorporate these perspectives. Tomorrow, you're all invited to register at the campus. There's a screenshot that shows how you're going to find the course in English, and here a screenshot showing you how you will find it in Spanish. So we invite you all, as Dr. Suzanne said, please walk through it, walk through the material, debate it with your colleagues at work, and share the discussions with your colleagues at the hospital, the healthcare centers, with your classmates, and send us your feedback on all the courses. Before you get your certificate, you'll have to answer a quality survey that we pay close attention to, both in terms of content and navigation, browsing in the virtual classroom. So finally, when you finish, when you complete the course and you've gone through all the material and you answer the questionnaires to pass, you're going to receive a certificate similar to this one. Of course, if it's in English, you're going to receive it in English with a 25, and you'll be acknowledged 25 hours, and it will be signed by Carissa Etienne, our director of PAHO. And to your right, you see that anybody that needs support to have access to the campus, if you have any problems with your keys, any problems that typically occur when we need to enter a portal, you forgot your key, your password, they don't recognize you. Well, there you have the help desk to help you. We have courses for TAP with over 20,000 participants, so we hope that this course will reach that figure and many more participants. So we are eager to receive you at the campus, and we wish you the best success with this experience. Thank you, Bremen. And Bremen, I give you the floor. Thank you, Gabriel. You gave us very good news. Tomorrow, starting tomorrow, people will be able to register the course. There were colleagues that were asking whether they would get a certificate or diploma, and that was in the chat and not in the Q&A panel, so you answered it. And thank you, especially for maintaining the service that you always provide when people have problems with just anything. Unfortunately, you things work properly. Now, let's go a bit closer to see some of the details of the course itself. So I'm going to invite my colleague, Ariadna Capasso, who will share with you some parts of the contents to see whether she convinces you and she generates excitement about this. A colleague just now at the chat was asking whether the material that we are using will be available. Well, you'll have the recording in the link that I put there, and from there you can draw specific links of some new things that are not included in the course. But in the course, there's a huge number of support materials of different areas that will be available for you if you want them. Ariadna, the floor is yours. Thank you, Bremen. Hello, good morning, good afternoon, everyone. The idea of my presentation is tell you what this course is about and what we want to encourage you, to invite you to go through it and speak of the contents and the structure. Basically, the purpose of this course intends to be hands-on, useful, so that the participants may complete the course and feel empowered and may have the skills to start planning, implementing, implementing and monitoring maternal and neonatal respectful treatment. We will speak of basic aspects and practices related to the field, and we're going to talk about the framework of rights, supporting it, and hands-on tools that you can use to implement some of the initiatives.
So the goals were to describe what is maternal and neonatal respectful care, why it's important, the current condition of all this, respectful care, lack of respect, be aware of the legal framework and international and national institutional rights, what supports them, and particularly develop skills in participants to use tools allowing them to initiate and monitor initiatives to improve quality and promote respectful maternal and neonatal care at the centers. As stated, the necessary time is 25 hours. The methodology, this is an asynchronous self-instruction course, so participants may access the course when they have the time available. They may do so during the months as required to do so. An important thing is that the course has two modes, one totally online and the second one offline, meaning that you may download them if you don't have access to the internet or limited access to the internet. You download it to your computers or cell phones or tablets and complete the contents not online, and this makes it more accessible. As mentioned, we will receive a PAHO certificate for those who complete the evaluation, and there will be a satisfaction component, and for this it is necessary to be online at the time, but it's that last evaluation component only. The course is structured into 3 modules. Each has different sessions. The first module is devoted to conceptual aspects and the framework of rights for respectful maternal and neonatal care. It presents basic concepts in the global situation and in specific countries. Likewise, the second module is a hands-on module. It has material to develop skills, allowing participants to implement initiatives in order to improve respectful maternal and neonatal care in the framework of quality of care. It's illustrated with case studies and specific examples. And last, module 3, for quality monitoring of different initiatives. I think somebody in the chat asked about the quality standards used in Mozambique, and I invite that person and others to form part of the course where you will have examples both from Mozambique and other countries and at world level used as indicators and quality standards in order to monitor the progress of different improvements and initiatives to in relation to maternal and neonatal care. To develop the material for the course, we conducted an extensive search in the literature. We also used the initiatives that are ongoing, as mentioned by Veronica Reyes, the existing frameworks and ongoing frameworks in relation to respectful maternal and neonatal care were used. Interviews were conducted with key informers and very importantly, we had feedback from a group of experts on the subject of respectful maternal and neonatal care. And I specifically wish to thank the members of the advisory technical group that during a whole year made their contributions to prepare this training course. We also worked together with a company with experience in distant education to prepare didactic material of interest and making the contents more friendly. One of the take-home messages we wanted to convey in the course is that it is possible to have a humanized and respectful childbirth, that we don't need major financial investments or infrastructure. It's rather more an institutional commitment, and from each of the individuals working in the health area, and more specifically with women who come for childbirth. It can be adapted without great investment, both delivery and neonatal care, to make it a positive experience both for the women, babies, and families in a framework of quality of care. The course used a series of modes and didactic elements to convey the information and develop the necessary skills as mentioned. On the one hand, we used artistic videos so that the students could sort of empathize both with the health team as with the women and perceive and internalize the possible challenges they may face both in the health team and the women themselves, their emotions, feelings, and expectations in and during delivery. We also used the interview modality with several referents in the area, providing concrete examples of how respectful maternal and neonatal care initiatives were implemented. They told us about their experiences, lessons learned, challenges, and how they faced them. Here we have the example of an interview made with a midwife in Chile who told us about the adaptations of the health services there vis-a-vis the increasing migration of women from Haiti, for example, and how the services were adapted at cultural level to this effect. We also shared the experience of the Salgado maternity, and we had Dr. Soto Conti with us, and she told us about how they ensure respectful maternal and neonatal care there, how they have involved families in the care of newborns and even those in intensive care. And she detailed the safe, family-focused maternal care model. Veronica Reyes was also interviewed, and she spoke in detail about the example in Mozambique and how they have monitored and assessed the experience there. So with the aid of these reference and the experience related, we've been able to show how it's possible to change this care paradigm. In many places, we illustrated the concepts using audiovisual material, in some cases, analogies to transmit what women sometimes feel when we don't have a respectful maternal neonatal care. In this sense, I will now ask Juan to turn on the video. Throughout the world, many women suffer abuse and mistreatment during delivery in the health facilities. This is against their right to receive respectful and dignified care before, during, and following childbirth, but also threatens their right to life, health, physical integrity and non-discrimination. Technological and cultural changes gradually led to dehumanization of care. In the way, we forgot that delivery and birth are a natural event. Often, gestating women are not protagonists or may reach decisions regarding their own health because other factors were interposed to their physical, mental, and spiritual and emotional needs. We must bear in mind that the fundamental causes for the lack of respect and abuse in the perinatal process are mainly social and structural, not individual, and include the context and the institutional culture where the health professionals are trained, the working conditions of the staff in the health facilities, gender inequality in society, class issues, and ethnic discrimination, among others. So to improve maternal and neonatal care, we must include changes at different levels in the health system and in the community itself, not only focus on the health personnel. So in order to improve maternal and neonatal care, we must modify the institutional structure within which we provide care. Training health personnel alone will not lead to improvements in care. Thank you, Juan. I'm going to share my screen again. Last, then, we had different activities which sought to present specific situations, leading the students to reflect upon them based on their own personal experience and what they would do if they had to face these situations that pose ethical dilemmas sometimes, and how they would react vis-a-vis these diverse situations. Throughout the course, the idea was to use illustrations and language and material that are inclusive and representative of the diversity of women's families and communities and cultures and contexts and situations. So with these different methodologies, the idea was to share a message stressing that whatever the resources we have, it is possible to take measures to improve maternal and neonatal respectful care. So we are sure that by the end of the training, the different participants will be able to count with these skills in order to implement initiatives to improve respectful maternal and neonatal care, ensuring that every woman and baby have a positive childbirth experience. Thank you for your attention. Thank you, Ariadna. Well, I think that your last words are essential because the idea behind this course is that whoever takes it first, well, if they are not sensitized with the topic, will become more aware of it. Second, to become more knowledgeable about the background in terms of rights, ethics, responsible and kindly care, everything that the course aims at. But more specifically, what you said last, the idea in that third module and using the learning in the other two, that who completes a course and is interested will have tools in order to begin to promote in their workplace the respectful maternal and neonatal care. I am not naive. I know there are enormous barriers when implement this, and this means that the critical mass will have to increase. But this is a first step that I think we must bear in mind, and you're all included as our allies. This course, as you observed, was conducted with support of many colleagues from different agencies and also had the support for the Spanish version of the US Agency for Development and for the English version, we had support from the Susan Buffett Thompson Foundation. Some colleagues were asking if the colleague had a cost. I said not to do it. Whoever wishes to take it can do it so free of charge, but it did cost. It had expenses, and it was extremely expensive, but that isn't wasting money, it's an investment. Thank you all for your time, and the colleagues who have been responsible for hosting this course, and more particularly all those participating today. I will now hand the floor to speak about the next steps in the course and what can be done for you to Dr. Suzanne Saruya, our director. The floor is yours.
Gracias, Bremen.
Thank you, Bremen. Every time that we reach this point at our meetings, I remember the YouTubers, the famous YouTubers that say, yes, register, give me a like. So, because not only do we use the funds from donors, foundations of USAID and Buffett, as Bremen said, but we also invest in the most important thing that we have. Ariadna, Bremen, Pablo, Gabriel, Veronica, and others that worked for this, and the people that prepared the course, and many that worked hard to provide you with a useful tool. So please use it, disseminate. There's almost 300 of us today. If we can tell 2 additional people, if we teach, if you work at a hospital, please spread the voice. I am, Bremen said that he was not naive, but I am. And I think that we should commit ourselves to generating that. And I'm going to give you, to tell you of the 16 days of activism that we are living. The epidemic sort of hit this. But during the pandemic, we had an epidemic of gender violence. We have to work against that. That is the key thing. And as I said initially, it's the part that involves the most important moment of people's lives, one of the most important moments of life. It is. I could mention many things, and I loved Gabriel's challenge. It is true. We have many courses in the virtual campus. All CLAP courses of the virtual campus of PAHO are free of charge. You just have to register. And I don't think that there's anything easier. So we invite you to know the campus and to make this succeed. And I want to thank that huge team, Juan and Nacho, that were in charge of the streaming, and then with the people with our translators that made it possible for our colleagues that barely speak English or speak English that to follow the session, and everybody that participated, Constanza, Gabriel, Veronica, Ariadna, and of course those 2 pillars of Club Bremen and Pablo. Thank you. And now, please, it's your turn to disseminate, to spread it, so that all the effort and all the funds will be worth it. So thank you, and I wish you a wonderful weekend and day end, and thank you. Maybe we could all open the cameras and get a brief picture.
Ahí tenés para la foto. ¿Te salió?
There, did you get the picture? Yes. Goodbye, everybody. Thank you. Thank you. Bye. Thank you. Bye.